So today's video is going to focus on skeletal injuries and disorders with a heavy emphasis on fractures. So disclaimer again, there are going to be some pictures that are pretty icky. Okay, so if you have a younger sibling around, or you get grossed out, we'll see a few pictures that are pretty icky, and then it will be mostly all X-rays. Okay, and I'll give you a warning when the icky pictures are coming. Okay, so a fracture in general is just any kind of break or crack in the bone. So it can be a full-blown break all the way across, or it could just be a crack that maybe doesn't even go all the way across. And our first classification for a fracture is whether it is considered a simple, which is also called a closed fracture, or a compound, which is also called an open fracture. So on this diagram over on the right here, you can see what we mean here. This is a simple fracture. It has gone all the way through the bone, so it's not just a crack, right? It is a complete fracture, but it has not broken through the skin. So it is a simple fracture because, again, it has not broken through the skin. It is a closed fracture. That's what we mean by open or closed, is whether it has broken the skin. Okay, so did it break the skin is what we mean by open versus closed. So this fracture over here on the right, this is a compound or an open fracture because you'll see here you have an open wound. And so these fractures are more serious, an open or a compound fracture, for a number of reasons. You have an open wound, okay, and so now you run the risk of infection, okay, by having this open wound. You also now have usually significant soft tissue damage that you don't usually have as much soft tissue damage when it is a simple fracture, because the bone hasn't moved, over to the side like that and torn through the skin. So disclaimer, there are some icky pictures coming up. If you want to close your eyes for a second, because I know you can't fast forward on Edpuzzle, okay, I'll let you know when it's time to come back. Okay, so as you can see here, all of these would be examples of open or compound fractures. Again, they are compound because they have more than one issue going on. They are a compound issue. Okay, so I have obviously here, I have a very large open wound that I would need to contend with, possible infection, including all the way down to the bone. Okay, this is not this gentleman's knee. That is actually his tibia, his shin. His knee is up here. Okay, his bone, this is a college basketball player, and this bone just snapped. Okay, so there is a significant risk of infection here, bone infection, blood infection. Okay, and then this would be a wrist here with an open fracture, okay, where it looks like the head of the ulna has pierced through the skin. Okay, if you closed your eyes, it's time for you to come back. Okay, so let's look at some different kinds of fractures. Okay, and you guys are going to be expected to, kind of be able to recognize these and know the characteristics of these different kinds of fractures. So the first one here is a comminuted. Okay, comminuted, that's an N, right? And so with a comminuted fracture, basically I have pieces or shards of bone. Okay, and we can see this in this fracture here, where this bone has broken into multiple pieces here. Okay, it's basically shattered. And you can have different severity of a comminuted fracture. It could shatter into tiny pieces. It could break into larger pieces. Depending upon the size of the fragments, will depend upon the repair. If it's large fragments that you can possibly insert pins or screws to put it back together. If it's not, then there might need to be some kind of metal rod or something put in place, and you may just have to clean out the debris. Okay? But again, a comminuted fracture, the bone is going to shatter. It's going to break into multiple pieces here. A spiral fracture is this one down here. Sorry, I jumped. So spiral fracture goes here. So a spiral fracture, as you can see that if you look at these arrows here, you'll notice one arrow is spinning one direction and the other one is spinning the other direction. And so the spiral fracture really is kind of referring to what caused it. You have these rotational forces going in opposite directions. So basically it twists the bone enough so that it will snap apart. Your issue with a spiral fracture, a lot of times, these can become an open fracture because the ends here are usually very sharp. Okay, these ends right here, and so they can easily pierce through the skin or tear the muscle. So a spiral fracture is more common in athletes, in particular in soccer players, because they plant their foot and then their cleats and their foot stays while their leg spins, okay, and it results in the spiral fracture. Okay, this one on the top here, this one on the top right above the spiral fracture, this is a green stick fracture. And so a green stick fracture is most common in children and kids, right? Mainly because their bones are still a little bit more flexible. Okay? And so a green stick fracture, it doesn't break all the way through. You'll see on this one here, you can see how it hasn't gone all the way through the bone because, again, the bones of a child are more flexible, kind of like a green stick or a young tree branch, right? Where you can break it and you can snap it and one side of it will snap. Right, and so you end up with one side of it snapping, but it's still held together down at the bottom, and the two sides have broken apart. Okay, and so that's why it's called a green stick fracture, because like a young plant, it will break, but it doesn't easily break all the way through. All right, this one over here on the right, where you can see where this bone has gotten flattened here. This is a compression fracture. Sometimes it's called a pancake fracture. So this is a compression fracture. This is very common in osteoarthritic patients where the bone has become a little bit more brittle, not quite as dense. And so the compressive forces, these are very common in the spine, the compressive forces here basically just squish that vertebrae down. The very old people that you see that are really hunched over, they most likely have some compression fractures. Unfortunately, there's not much that can be done for these. And so they just kind of have to live with them. And it can become very painful. And if they have multiples, they get a lot of, like you can see this one here, there's two here. And so they're starting to see some of that curvature, some of that hunching, which can, if there's enough of them, compromise breathing and things like that. Okay, our one down here at the bottom left here, this one is an avulsion fracture. Okay, it's not a calcaneal. This one in particular is a calcaneal avulsion fracture, but the type of fracture in general is just an avulsion fracture. And basically what happens here with an avulsion fracture is you pull a piece of the bone off. The muscle, so in particular here, their calf, the muscle has gotten too strong and it will pull a piece of that, it will pull that piece of bone off. So that will definitely require surgery. They'll need to pin it back to the bone to try to repair it and basically repair the muscle because that muscle will curl up. And so they'll need to straighten it back out and repair it. And then we have two more. So our next one here is a stress fracture. So, whoops. So the stress fracture, most common in repetitive use. So runners are sometimes susceptible to stress fractures. Okay, so stress fractures are small, minute. Okay, you'll see these really and truly are cracks. They don't necessarily go all the way through, okay, but they are definitely due to repetitive overuse. So that's like the example you would see here. This is a runner's foot, right? That has been repetitive pounding on the pavement. And so it can result in these stress fractures. And our last one here is this impacted fracture. And so the impacted fracture, basically the two ends of the bone get shoved together. So this will result, like for instance, this is the arm. And so this most likely resulted from them falling. And so you ready for one of my amazing pictures? So as they were falling, they stuck their arm out to catch them, and that jammed up the bone. You see this some in car accidents where the person is sitting in the front seat, in particular, usually the driver. And, we've got the steering wheel and then the rest of the car here. And the car pushes into them, which then makes their femur come impacted together like that. Okay, so with this impaction fracture, This usually requires traction, where you have to pull the ends of the bone apart because they're smushed up into one another. So traction, which will pull on the bones, pull them apart. It may also require some form of surgery to help this heal. Depending upon severity is where you're going to get surgery. Spiral fractures commonly require surgery. Avulsion fractures always require surgery. Comminuted usually, impacted usually. Stress fractures very rarely require surgery. Green stick fractures don't require surgery. Compression fractures, they're usually not anything that you can't do any form of surgery to repair them. Okay, so these X-rays, we're going to incorporate some of these into the Ed puzzles, see if you can figure out what they are. I'm going to give you a little bit of kind of description and then give a pause for a second where I can insert the Ed puzzle question. So for fracture A here, really kind of pointing out here that I've got a variety of pieces of bone here. Okay, and so this bone has broken into pieces. This is their femur down by their knee. Right down here is their knee. Okay, so this is the end of their leg that has shattered into pieces. For B here, you can see how this is their spine. And you can see here where the bone is now. Okay, this is the vertebrae below it. So you'll see that the vertebrae there in picture B. So the vertebrae that we're focused on here is significantly thinner, much smaller. Again, here's the vertebrae B below it. Okay, so that's the height that it should be. Okay, and this is how squished it up it is now. Set C here has multiple small little fractures. They may be a little hard to see. It's a little dark. Okay, number 4, I think, is the easiest to see. Multiple small fractures. That is a foot. If you are unsure what you're looking at, you're actually looking at somebody's right foot. Okay, and so there are multiple small fractures here that are most likely due to overuse. And then fracture D here happened in the shin. You can see there is these sharp ends here of the bone. That what happened where the foot was still, the foot was planted, and the leg spun. And so basically there was force in this direction and force in this direction. Okay, and so it resulted in those sharp ends of the fracture there. Again, common in certain types of athletes. Okay, so a few more X-rays that we're looking at here. So this one is a hip, okay, and this is the neck of the femur. And what that should normally look like, not quite that big, is like that. So as you can see, the neck is significantly shorter because it has been pushed or shoved together like that, which has made that neck look a lot shorter. So it would have to be pulled apart and opened up there. Sample F here is on a child. You can tell because the epiphyseal plate here is still open. It's not closed. That's not another fracture. There is a small fracture here, but you'll notice it does not go all the way through the bone. It just goes part of the way through the bone in the child. In G here, you're looking at a piece of bone here that has been ripped off or pulled off. Not this one, that's the kneecap, that's their patella. Okay, but this piece of bone right here has been pulled off, and so it would need to be pinned back down. Okay, so that they can repair that. So they've ripped off. So what's happened is the muscle has ripped a whole piece of bone off. So hopefully you were able to identify those different kinds of fractures using the information from the previous slides. So let's look at how we get better from a fracture. So we have 4 basic stages to healing from a fracture. So the first one is the hematoma. Basically, the hematoma is the big bruise. Right? I'm going to get a lot of swelling here because bone, remember, is a connective tissue, and which means bone actually has a really good blood supply. We have all those osteons with all the blood running through them, blood vessels running through them and connecting. Okay, so if I break the bone, I'm going to bleed. Okay, and so I form this. There's a significant amount of swelling, which is initially beneficial because it helps stabilize the bone here. Okay, and we are letting all this blood flow coming to the area is also bringing white blood cells with it, things like that. So the next step is we're going to lay down some fibrocartilage. So we're going to have this fibrocartilage callus formation. So basically, you can see what's happening is your body is just trying to connect the two ends of the bone again, right? So we're just kind of laying down like a network of fibrocartilage that the osteoblast and then the osteoclast can help remodel into actual bone. But we'll lay down that fibrocartilage callus to help stabilize and connect the two pieces of bone. And then you're going to start laying down the bony callus. And that bone will consist mostly of spongy bone at first. Okay, so just laying down the bone using the callus of the fibrocartilage formation to help form the network that the bone will be there. And then once you've laid down new bone in the area, you've got to remodel the bone. You'll see how in stage 3, when I lay down the bony callus, like I don't have a medullary cavity yet. I'm going to need to carve all this out, right? Use those osteoblasts there the osteoclast there to help carve that out. The osteoblast, to fill in some cortical compact bone on the edges here. And you'll remodel. The bone will always have a little hypertrophy there where the fracture happened, trying to helping heal it, helping stabilize it. It'll look thicker, appear wider on X-ray, which is how they can see former injuries and such on X-ray. But these are your 4 basic steps here. We form the bruise or the hematoma, the fibrocartilage callus, the bony callus, and then we remodel it into the original bone shape. All right, so let's switch from bone fractures to epiphyseal injuries. So these are injuries that are going to occur to the epiphyseal plate, the articular cartilage at the very end, or the apophysis. Okay. What the issue here with these is that they can cause premature closure of the growth plate. So a child, you'll notice the X-rays here are repetitive stress in a female and a 14-year-old gymnast. So here's the epiphyseal plate. So she is still growing. So she should, these have not fused yet. Her bone should still be getting longer. You can see there that she's got some irregularities at these epiphyseal plates here. Some thickness, that's the extra whiteness here, laying down. Okay. As they zoom in a little bit closer and they use the CT scan, you can see how ragged and damaged and torn up these epiphyseal plates are. If you have a fracture, if you damage that epiphyseal plate, it may not heal. And so what it can end up doing is forming, let's just do like a generic bone here. You could end up forming the line before you should. And so you can actually end up with, wow, this is extra terrible. You can actually end up with one bone that is shorter than the other because the epiphyseal line fused, the epiphyseal plate fused due to the injury. Okay, another one is called osteochondrosis or Osgood-Schlatter disease. Some of you may have experienced this or had a sibling or somebody that had this. This is more common in boys, especially like late middle school, early high school, because they're growing so much, and as they start to build up a lot of muscle here in the quad, it can essentially just pulls too much on the tibia. So they get a lot of inflammation and a lot of pain just below the knee where the attachment site for the quad is pulling on the tibia a little more than we would like. Okay, our last thing that we're going to talk about here is osteoporosis. So with osteoporosis, we have the minerals that we lay down in the bone. So the bone mineralization is relatively low, which means that the strength of the bone becomes abnormally low. Osteoporosis is more common in elderly women, and it begins as osteopenia. Osteopenia is just a reduction in our bone mass, but we don't have any fracturing yet. Osteoporosis, we start to have the fracturing due to the reduction in the bone mass. And there are two basic types. Type 1 is postmenopausal osteoporosis. This is going to be due to the hormone change that occurs in particular with estrogen and progesterone with women as they go through menopause. And that has a big impact on their bone density. And so the fractures will start to show up about 15 years post-menopause. The bone has been steadily weakening since the onset of menopause due to the hormone fluctuations. And so then those fractures, it takes a while for the bone to weaken enough to develop into fractures. So in the meantime, you have the osteopenia without fractures. In type 2 osteoporosis, this is age associated. So this is not gender specific. Again, postmenopausal osteoporosis is going to be females only. So type 2 is going to be males and females. And this is really just due to age. As the bone density declines as we age, we get this age, we can develop this age-related osteoporosis. So we mentioned earlier how osteoporosis can cause the stooping. You can see here this comparison here of a healthy bone versus an osteoporotic bone. You can see how there's the open spaces in the bone here are much larger, much bigger. The bone is a lot more brittle. And so we can start to develop these fractures. You can see in this imaging here, we have two compression fractures. We can see it in the diagram here. You can see the progression, right, where the patient is standing upright. And they develop one compression fracture, so they start to get that curving. As they develop more compression fractures, they start to curve even more. And so they develop this stooping because, again, there is not any way to fix those compression fractures. And then we have what is called our female athlete triad. Okay? And so this is not all a bone disorder, but one component of it is the osteoporosis. So the female athlete triad is an eating disorder, amenorrhea, which is the loss of their menstrual cycle. A is no or none. So they're having no menstrual cycle or no periods, and osteoporosis. This is most common in endurance athletes. So your marathon runners, your like super long distance swimmers, or appearance related sports like ice skating or gymnastics or dance, and that commonly is going to start there with the eating disorder because of the appearance related. So they're trying to maintain this very low body weight. And so in trying to maintain this low body weight, again, they can develop the eating disorder. It affects their hormones, again, which can cause the amenorrhea and the osteoporosis. And this will lead to an increase then in stress fractures and potentially irreversible bone damage, depending upon the length of time and the severity that this has been going on. Okay, so we've got a variety of bone issues that we're looking at with our emphasis on fractures. And so we will do some review of these in class as well.